So this is the fifth talk in the neurology series, and today we're going to talk about encephalopathy. A lot of people, when they hear this word, they don't really know what it means, but it's actually quite a straightforward word. The trouble is encephalopathy has a vast array of differentials, so you have to do a bit of work when you see a patient with encephalopathy in order to determine the cause. So first, how do you define it? There's a lot of opathies in neurology. Encephalopathy really just means brain disorder. It's a fancy word that simply means that. There's also myelopathy. So when you hear that word, the person just means there's a spinal cord disorder. There's, of course, radiculopathy, which I never learned about in medical school, but it's extremely common. And that's a nerve root disorder. There's plexopathy, a plexus disorder. Hopefully you're getting the idea. Neuropathy, of course, most people know about those. Nerve disorder. Myopathy is a muscle disorder. So neurology is a broad area, and we use these long words that often sound a bit funny to just describe things in a very general sense. So don't be afraid by the words. Don't be afraid of the words. Make sure you speak English properly. So the term encephalopathy simply refers to a clinical syndrome of altered arousal and/or awareness. This is if we want to make it a little more specific. And I'm just going to stick to these two terms, arousal and awareness. Consciousness is a whole sort of different bag, and we're going to stay away from consciousness in this lecture. Okay, so arousal. Arousal describes the degree of engagement between the brain and the world. So it's a spectrum that ranges from wakefulness to sleep, and you can subdivide those. So wakefulness, you could say that you have someone in a high state of attention, which all of you are in right now, I'm sure. But then on the other end, it could vary. It could go to relaxed wakefulness. And sleep ranges too from, basically the two main stages are non-REM and REM. And so there is quite a spectrum. And if you do an EEG on someone, the frequencies of the waveforms that you see correlate somewhat with the degree of arousal. So if you have, delta or theta slowing, that person's probably asleep or extremely drowsy at the least. Whereas if they are in relaxed wakefulness, it'll be sort of an alpha frequency. And if they're really concentrating hard, like all of you guys are, it'll be beta or even gamma frequency. So it changes. Okay, so in wakefulness, basically the brain interacts with the world. Wakefulness is a state where the brain is not changing too much on a global scale. It's interacting with the world and allowing you to make your predictions, as we discussed in the third series of the neurology series. Third lecture of the neurology series. And wakefulness is probably driven by the thalamus and the midbrain reticular formation. So these two structures are very important to giving you your ability to be highly awake and aroused. So damage to either of those two structures will result in, of course, drowsiness. Now in sleep, think of sleep as, of course, the brain is not readily interacting with the world. Sleep is where the brain is kind of adjusting itself to all the daytime things that it learned in the preceding days and the day before. So that's where the brain can change. The connections are changing, the synapses are altering in strength. And so you can see that basically this is why sleep is there. This is probably the main reason. There are many theories on sleep. But it must exist for a strong reason, because if it didn't, the negative selection pressure against sleep, like when you're asleep, you can't defend against predators, you can't, it's a waste of time in terms of foraging for food and all that. There must be a good reason it exists, and probably it's the state where the brain is able to change itself by using the daytime experiences that it learned previously to make it better able to interact with the world in future. So there's a vast sleep network in the body. Think about this. No matter how bad the neurological disorder, think of massive catastrophic strokes or terrible neurodegenerative diseases, sleep is almost always still okay. The person can still fall asleep and wake up. And that's because the sleep network is quite vast. It resides in areas of the thalamus, the pons, and the medulla. But you'd need a catastrophic hit to the brainstem and thalamus probably to really screw up sleep to any significant extent. Now, awareness is the other side of the coin. Awareness, we've already talked a bit about in the third talk of the series. Awareness describes the extent to which the brain can make successful predictions about the world. So basically, the more predictions you make and the more accurate they are, the more sort of intelligent or aware you are. And that's the way I think of the brain. So again, when we're younger, we create an inner model of the world. Remember, the cortex is sending 10 times as many connections back to the thalamus as the thalamus is sending to the cortex, right? So we see and hear mostly what's already inside our head. And we do sense reality, but it's probably the minority of the contribution, certainly as we get older. And remember the checkerboard. A and B, are they the same color or two different colors? They probably still look like two different colors to you, but I can assure you they are the same color, and you didn't see reality. You saw what your brain told you was there. So remember, awareness is heavily influenced by that inner model that is somewhat unique to all of us. Okay, and making predictions about the world, that's the main function of the cerebral cortex, probably. So that can be damaged in encephalopathy too. So how do you grade encephalopathy using those two terms? Well, normal consciousness would be high arousal, high awareness, right? And a coma, or deep sleep, so deep sleep in non-REM, and anesthesia, you'd have basically no arousal and no awareness. Now there's a spectrum between them. Encephalopathies range from slightly impaired arousal and or awareness to near coma. So encephalopathy is everything in between. Now there are some exceptions. For example, you could have high arousal and virtually no awareness in a state called the vegetative state, persistent vegetative state, permanent vegetative state. That's where a person has sleep-wake cycles and they are aroused when they're awake, but they have no awareness. And conversely, you can have very low arousal, but extremely high awareness when you are in REM sleep and you're having a dream. You're in the dream, you're interacting within the dream, and you're quite aware. And some people have this thing called lucid dreaming, where they can actually control the dream and know that they are dreaming. So those people are very aware, and yet if you look at their body, they're not aroused at all. So encephalopathy is not everything that's between normal consciousness and coma, but it's almost everything. Okay, this is the most important slide of the talk. Whenever you face encephalopathy, you have a patient on the ward that you think is encephalopathic, and this is generally a very easy thing to identify. They're a little drowsy, or their awareness is a little off, their arousal is a little off. They're probably encephalopathic, and then you just go to this slide and you'll have an umbrella approach in order to try and figure it out. So we'll go through the most important common disorders of each of these categories, not all of them. It would be far too long a talk if we did that. But basically, I'll talk about a couple examples from each of these categories in red. The two on the right, electrolyte disturbances and organ-related causes of encephalopathy, I will just mention very cursorily because they're sort of the least neurological, perhaps, of these etiologies. So again, you can't treat an encephalopathy if you don't know the diagnosis. You must know the diagnosis. And once you get the diagnosis, then you can often, not always, but often treat the encephalopathy. Okay, so we'll start with the brain injury-related encephalopathies. Now, these are hemodynamic in nature. Usually there's a loss of systemic blood pressure, direct force on the brain, so blunt trauma, and the brain is a victim in these cases. One in particular we get called to see, often in an ICU setting, is a Hypoxic-Ischemic Encephalopathy. Tumors can give it to you though, trauma, like I said, and there's one called chronic traumatic encephalopathy. It's also known as the punch-drunk syndrome. Yeah, boxers are very prone to this if they've been fighting for a number of years. But also people who play American football and perhaps other contact sports are prone to this. So the hypoxic-ischemic encephalopathy occurs when the brain is deprived of adequate oxygen, but the deprivation is not total. So I've shown you a couple of scans there, and you can see in the circles. So on the top and bottom, the circles are outlining the neocortex, which is again the thin ribbon of envelope of neurons surrounding the brain. And it's a bit indistinct in the top one, and in the bottom one you can see that the cortex is difficult to see at all. There should be a clearly identifiable ribbon, slightly different color there, and you can't really see it. Most of these occur in babies as a result of birth asphyxia. In adults, though, it occurs generally from a cardiac arrest, such as a massive heart attack. But it can result from other things: choking, drowning, strangulation, smoke inhalation, and so on. So this one is tough to treat, and it's usually pretty obvious what the cause of the encephalopathy is early on. Hypertension-related encephalopathies result from disrupted cerebral blood pressure regulation. Now, normally cerebral autoregulation is maintained. The perfusion of the brain is strictly maintained even when the systemic circulation is going out of kilter. So things have to break down considerably before this encephalopathy develops. There's two of them we'll talk about: hypertensive encephalopathy and its nastier cousin called PRES. But there's other causes of this, as you can see. Preeclampsia, renal failure, and immunosuppression can all do this. So hypertensive encephalopathy is in the setting of chronic hypertension, where the cerebral autoregulation system is gradually shifted higher and eventually gets overwhelmed, which is not normal. So you can do MRI imaging, special sequences of MRI imaging to show these things called microhemorrhages or microbleeds. Those are the little black dots there in the middle of the brain. And basically you get a gradual loss of the blood-brain barrier integrity, increased cerebral perfusion pressure, you can get the bleeding, you can get fluid exudates, and so on into the brain. None of that's supposed to happen if cerebral autoregulation is performing adequately. It generally presents in a chronic fashion, but can present subacutely over 1 to 2 days. And the blood pressure is, I would say, almost always over 200 systolic millimeters of mercury. And nobody with a blood pressure over 200 should be sent home from hospital until that's controlled. And the symptoms usually would include things like visual disturbance, headache, nausea, vomiting, and of course seizures. There's a slight variant of this, which is often presents somewhat more acutely and more severely, called PRES, or posterior reversible encephalopathy syndrome. Same mechanism as hypertensive encephalopathy, but it's a bit more distinct because the encephalopathy is more marked, so there'll be drowsier or even worse arousal/awareness. And they'll have visual disturbances that can be quite pronounced, including hemianopias, neglect, hallucinations, even cortical blindness, headache, nausea, vomiting, and seizures, and possibly even status epilepticus. What you look for on the MRI are these hyperintensities, so slightly too white regions in the occipital and parietal lobes. That occurs in at least half of all cases. And you can, of course, get the microhemorrhages or even larger hemorrhages as well as part of this. So this is quite a nasty syndrome that one can treat. We had a patient come in last week with this. Well, patient we were involved with, and the outcome can be good if you get onto it quickly. Epilepsy can give you encephalopathy, so we often hear about non-convulsive status epilepticus. That's a common etiology for encephalopathy. You can get an epileptic encephalopathy. Basically, a person can develop a chronic encephalopathy from quite severe chronic long-standing epilepsy. And of course, a postictal state will make someone encephalopathic. But we'll talk about non-convulsive status because that's what people often are concerned about missing. So think of non-convulsive status epilepticus as status epilepticus minus the prominent motor symptoms. It has to last usually at least 10 minutes, typically at least half an hour. It can go on for hours, even days. And there has to be evidence of seizures on the EEG. Now, I've just put up an EEG to show you a typical spike and wave pattern, not necessarily a non-convulsive status epilepticus EEG. Non-convulsive status is very subtle. The encephalopathy is not pronounced. They don't present in a coma, usually. They present with a very mild reduction in arousal and or awareness. So maybe even just mild difficulty holding a conversation or mild memory deficits. Diminished responsiveness. So for that reason, it's underdiagnosed because it's missed. And then when it's found, it's often, it can be overtreated because quite frankly, it's really important not to miss it, of course, but it's got a very low likelihood of producing lasting neurological harm. So important to think about it, but don't beat yourself up if you miss it for, a day or two even. Encephalitis, this is the most important cause of encephalopathy to be aware of because this one can have a really great outcome if you get onto it and a really bad one if you don't. These occur generally from infectious or autoimmune related disorders of the brain. This is the differential that I use when I think of encephalitis. So infectious, autoimmune. Now, when it comes to infectious, by far the most common ones are the viral encephalitises. And you think of herpes simplex viruses, varicella zoster virus, enterovirus, HIV, and the JC virus, which gives you that condition PML, which can be seen with excess immunosuppression in multiple sclerosis, which we spoke about in last week's talk. There are other causes of encephalopathy, though, encephalitis, that are infectious. So bacteria, protozoans, fungi, prion-related disorders such as CJD, and of course, sepsis itself can give you encephalopathy. So it's important to think broadly and determine which of these is a responsible agent if you think you have an infectious encephalitis. Now, on the other side, you have autoimmune encephalitises as well. So everyone here has heard about limbic encephalitis, and there are a number of antibodies, this list is not comprehensive, that are responsible for that. So these are immune-mediated. The immune system is, you can think of it as the immune system attacking the brain in some sense. There's one in particular that we see once in a while called anti-NMDA encephalitis, where the immune system attacks the NMDA receptors in the brain. It's usually in younger women, and we'll talk about that in a slide. And of course, acute disseminated encephalomyelitis, ADEM, which we also mentioned last week. That's an autoimmune disorder as well. So viral encephalitis, how do these occur? Basically, a virus gets in the brain And the virus would normally be suppressed by a healthy immune system, but for whatever reason, it is not suppressed. It might be a latent virus that's in the brain that's reactivating in a setting of weakened immunity, such as the JC virus. Or maybe it's another virus that got there, possibly through the blood, through some kind of defect in the skull. People are not quite clear always how these viruses get in there, but the body is full of viruses. And the most common usual suspects are HSV1 and 2, VZV, and enterovirus. And if someone has HIV, all these things become much more possible. So when do you suspect this? The person comes in with, it says 24 to 72 hours. I would say even a few hours of encephalopathy, high fever, headache, nausea, vomiting, seizures, or focal neurological signs. So if you have that, especially you got a fever, suspect a viral encephalitis. Your CT head may show hypodensity in the temporal lobes. So it'll be too dark in the temporal lobes, shown by the circle there. And that would be a case that's gotten away on us, because that shows that there's probably lasting damage and infarction. So you can see how severe they can be if you don't catch them early enough. The MRI will show hyperintensity, so too much white on the MRI, as opposed to the too much dark in the CT. And this would be, again, another one that's really quite an impressive viral encephalitis, affecting the right temporal lobe and probably parts of the frontal lobe and maybe even the parietal lobe. The lumbar puncture will generally show at least 5 leukocytes, maybe more. And basically, here's the take-home message. If you think you might have an infectious encephalitis, it's probably by the numbers viral. So you must treat as quickly as possible. Like, don't wait for imaging or anything. With intravenous acyclovir, 10 milligram per kilogram, 8 hourly. Any delay in treatment can allow the virus to produce more damage quite quickly, resulting in a worsened long-term outcome. So if you even suspect this, just start the acyclovir. You won't do any harm to the patient unless they have an allergy to it, but you may produce a lot of benefit. Limbic encephalitis is a little more subtle. It's subacute days to weeks, so doesn't usually present quite as aggressively as an infectious one. And you get short-term memory deficits as the hallmark symptom. So the person will often, or someone they know will complain that they have short-term memory problems for the last few weeks or months. And they could also have some psychiatric symptoms, worsened mood, hallucinations, delusions, and of course they may have seizures. So the circle there, this is a MRI showing you a hyperintense region in the left mesial temporal lobe. Mesial temporal lobe just means like the medial part, or you can think of it as the, I don't know. That's the way to think about it. And probably on the right there's a little bit of hyperintensity too that I haven't circled. So it's probably bilateral. Now, of course, the limbic encephalitises are mediated by antibodies. And some of those are strongly associated with cancer, resulting in a paraneoplastic limbic encephalitis. So a couple of examples would be the anti-Hu encephalitis, which tends to target the lower brainstem. And in addition to the above symptoms, you get hypoventilation because your respiratory centers are down there. And that's often associated with small cell lung cancer. Anti-MA2 encephalitis, it's the upper brainstem that gets targeted, and that can produce a gaze paresis. And that's associated in particular with testicular cancer. So these paraneoplastic syndromes are they can be quite distinct, not always, but the clinical situation can give you clues. Now, some antibodies have a variable or no known association with cancer. So a couple of examples of those would be the anti-LGI1 encephalitis, which gives a movement disorder, a sleep disorder, or ataxia, and seizures are extremely common. You might not get all of these, you might only get 2 or 3 of them, but these are common presentations. There's another one called Casper-2 encephalitis. We see this once in a while. It can give you this thing called Morvan syndrome. where a person has a severe reduction in sleep, muscle twitching, and cramping. I believe we had one of these a couple months ago. So again, the MRI shows hyperintensities in those mesial temporal lobes. This is now a coronal view. And it can show it in the basal ganglia or basal nuclei as well. Anti-NMDA encephalitis is the most common autoimmune encephalitis. It usually affects young women of non-European origin. And this is usually quite a distinctive clinical presentation. And we'll get a patient referred to us by often the psychiatry unit every few months with this disorder. So the young woman who generally has no medical history will have a viral-like prodrome of headache and fever for a few days or a week or so. And then there'll be another few days or a week, perhaps, of psychiatric symptoms, usually in a young woman who's never had a psychiatric history. And it can range from things like depression to anxiety and hallucinations, any of those things. This will be followed by, and this is the point where the person is usually admitted to a psychiatry ward or some kind of psychiatric care. And then after that's been going on for a few days or a week or two, these dyskinesias, particularly involving the mouth, will appear, and they might start getting seizures, catatonia, so episodes where they're very unresponsive 1 minute, and then they're sort of, so very low arousal 1 minute, and then high arousal the next. And hypoventilation and autonomic instability, their blood pressure and heart rate can go up and down quite tremendously. So if you know what to look for, this is not that difficult a clinical diagnosis to make. The MRI is usually normal, not always, and the EEG may show this pattern called extreme delta brush. You get these large, slow waves, which are superimposed by a higher frequency waves. It's showing it there. Basically, you get these big, you can see the big waves and then little waves on top of it. That's the delta brush. It's not always there. ADAM is a sudden, widespread attack of brain inflammation. This is often triggered by a viral infection, sometimes a vaccination, and it mainly occurs in children 1 to 3 weeks after the infection, and it can present fairly acutely, but usually subacutely, with encephalopathy, fevers, the usual stuff, and seizures, of course. Again, the MRI is quite distinctive for ADAM. It has usually multiple hyperintensities, and they have a smudged appearance, like someone just sort of smudged paint on the MRI. And they're multiple, bilateral, and it says asymmetric. Yeah, it's generally asymmetric. So yeah, and not a scan that you can forget. Drug-related encephalopathy, exposure to a medication or drug. There's 3 to know about here: the Neuroleptic Malignant Syndrome, Serotonin Syndrome, and Wernicke's Encephalopathy. And again, we had a patient last week on the neurology ward with Wernicke's. So you hope you're starting to see that you have a vast array of different encephalopathies, but you do see, certainly in neurology, you will see them not infrequently. Of course, other things can give you encephalopathy: alcohol, sedatives, anticholinergics, and opioids. All those drugs can do it too. NMS, the Neuroleptic Malignant Syndrome, is actually life-threatening. It's very important to identify. It can occur in response to antipsychotic medications, most commonly haloperidol, promethazine, and chlorpromazine, so some of these older antipsychotic medications. But any of them can do it. And it's got this presentation of course, encephalopathy. They get very rigid in their muscles. Lead pipe rigidity is the expression used to describe them. They have a high fever, and autonomic instability is also quite common. And this is not going to present with the sort of orderly time progression of the NMDA encephalitis, right? So some of these symptoms are very similar to that, but it doesn't present with the same orderly progression that one does, usually. There's always a usually in there. No single test can diagnose this. The CK level can be helpful. It's elevated in the majority of cases, but really it's clinical diagnosis at the end of the day. Treatment's pretty straightforward, right? Yeah. remove the offending medication. Serotonin syndrome, it's kind of similar. It also can be a life-threatening reaction, and usually it occurs when there are 2 or more serotonergic medications. The worst combination is an SSRI with a MAOI. So if you are thinking of starting an SSRI and or a MAOI together in a patient, I won't say never do it, but think carefully before you do that. But other medications can do this too. So TCAs, tricyclic antidepressants, that is, metoclopramide, ondansetron, tramadol, and triptans. So this is a very rare syndrome, but just be wary of combining these things. And the person will present with 1 day, within a day, so it's fairly sudden onset, with a triad of encephalopathy, neuromuscular hyperactivity, and autonomic hyperactivity. So they will get myoclonus or hyperreflexia or tremor, and then for the autonomic side of things, the usual signs of autonomic hyperactivity would be shivering, sweating, fever, tachycardia, diarrhea, sympathetic nervous system a bit on overdrive. No single test can diagnose it. Treatment, again, remove the offending medication, supportive care. You might need more than that, but we're not going to talk too much about the treatment of all these different things in this talk because it's just not enough time. Wernicke's encephalopathy. That occurs as a result of biochemical lesions in the thalamus, and you can see the circle there is circling the medial thalamus, and there's a hyperintense region there. This is exactly what the MRI for our Wernicke's patient looked like last week, and it can be kind of subtle. It may even be missed, but hopefully you can see quite clearly that that's abnormal. And it can also affect the hypothalamus or brainstem in the setting of thiamine deficiency. And this actually results in cell death when you have inadequate thiamine for long enough. It most commonly occurs in the context of chronic alcoholism, but not only in that context. It can occur with prolonged starvation, a disorder of pregnancy that results in severe vomiting called hyperemesis gravitarum, and bariatric surgery. So if someone has, this is quite a rare disorder, thankfully, but if someone has any of these risk factors and they present with encephalopathy, do suspect Wernicke's. It's classic triad. Again, you might only get 1 or 2 of these. It's rare you get the classic triad in all its glory in neurology. They'll present with encephalopathy, ophthalmoplegia, and ataxia. And I've written there, only 10% of people present with all 3. Okay, so electrolyte disturbances, I'm only going to briefly mention. You can get encephalopathy from a vast number of electrolyte disturbances or the glucose level. So I've just listed them there. They're easy to test for, right? You just run the proper blood test. So if you order your electrolytes and make sure magnesium and phosphate are in there, you will get all the information you need to know if this is potentially a problem. Again, the blood test for magnesium is not very reliable at all, so that's not helpful. But in this setting, it may well be helpful. Organ-related encephalopathies, so a person can be encephalopathic, not just from a brain disorder or an electrolyte disorder, but from a general dysfunction of almost any of the other organs. So you can get a liver-related hepatic encephalopathy, lung-related pulmonary encephalopathy, kidney-related uremic encephalopathy, Hashimoto's, thyroid problem, and adrenal failure. So think systemically if you have someone with encephalopathy too, especially if there's a known pre-existing medical condition, then you want to check the status of that. Okay, so you've got someone with encephalopathy. You know all the differentials that you have to look for now because we've just gone through them. Again, remember the history and exam will be more important than any of the tests I'm about to describe in diagnosing the encephalopathy. But that being said, this is a standard panel of tests you can do to help you diagnose any encephalopathy to a reasonably good degree. So first, of course, blood tests. Shoot off some bloods. And this will really help you figure out if there's an electrolyte disturbance or an organ-related encephalopathy. So your complete blood count, your electrolytes, kidney functions, liver function tests, TSH, CRP, and cultures. That is what I would do. And of course, if there's fevers, the cultures are very important. If there's no fevers, you know, you could argue that that one could be omitted, but I must admit I would probably send it off anyways. An arterial blood gas is always a good idea to make sure that, you know, we haven't got a problem with respiration. A CT head to exclude a brain injury related issue, particularly if the history fits, and a chest x-ray because sepsis is so common, particularly in the elderly, as a source of encephalopathy. They'll often present with drowsiness as the main symptom, encephalopathy. And urosepsis is, again, common in elderly patients. So do a urinalysis. Now, especially if there's a fever, you always start your acyclovir, remember that. Just start it and perform a lumbar puncture at some point. The lumbar, if you started acyclovir, you don't have to rush the lumbar puncture. And if you're really worried about doing a lumbar puncture, do it within the next few hours. But generally, it's good to get your MRI brain first, if you're going to get an MRI, before the lumbar puncture, because the lumbar puncture itself can induce some artifactual changes in the MRI. So if you have the time, get your imaging first, like the next morning even, before the lumbar puncture. But if you need to do the lumbar puncture, you need to know now. Go ahead and do it first. The lumbar puncture is, of course, very good for seeing if there's an encephalitis picture. And this table just shows you some rough estimates of what you might expect to find with each of the various parameters, depending on the etiology. I always say to people to measure opening pressure in the lateral decubitus position, so lying on their side, because you never know when someone, it could be even a few weeks or months later, is going to ask, what was the opening pressure? And although it may not seem relevant at the time, why would you not do it? It's good to always do it. You get good at measuring it, and then it's never a difficult thing to measure later. Glucose, protein, cell count, gram-stain cultures obviously are very important to check. Those tend to be fairly standard. You'll have to add on to the request form VDRL, that's looking for syphilis, HSV1, HSV2, VZV, enterovirus, serology, and PCR. Your lab may not do both of those, but there's no harm in requesting as much as you can. Some people I'll check for Cryptococcus, and that's usually an antigen test or the India ink stain. I think that's good to do. As a neurologist, I don't want to miss it. I have diagnosed, I think, at least 2, maybe 3 of these. Again, the treatment's fairly straightforward. If you don't catch it, it could be bad. And oligoclonal bands. Okay, now other tests depend on the clinical context. You, of course, might want to get an MRI, brain, or even angiography to look at the vessels. And this will tell you if there's a brain injury-related issue, hypertension-related, PRES, and infectious encephalitis with hyperintensity in the medial temporal regions. And then some blood tests if you're thinking of limbic encephalitis. This is a more complete panel of the antibodies. Again, this is not complete either. So there's a lot of sources of limbic encephalitis. Now, most hospitals will have a standard panel, so don't go down and write each of these on the form. Ask, if you're unsure, call the lab. Ask for standard panel for limbic encephalitis or, you know, along those lines, and they should be able to give it to you. NMDA, of course, presents with a quite typical clinical picture, so you can ask for that one specifically in case it's not part of the panel. And I find it useful to check for HIV in any kind of encephalitis, infectious or otherwise. An EEG can be helpful. Most commonly, that will be useful to exclude non-convulsive status epilepticus, of course. And a CT chest abdo-pelvis, if you're thinking of a paraneoplastic encephalitis, so also known as a paraneoplastic syndrome. then you might need to do a CT scan of basically the whole body, the chest, abdomen, and pelvis, to be sure. Okay, so that's our tour de force of encephalopathy. There's really no other way to cover it comprehensively that I could think of other than this, to just sort of wade through it. Just remember there's a disruption in arousal and or awareness, and it can be very subtle. It can even present with just mild memory deficits, a slight person slightly off in the conversation, or it can be very severe. Someone's almost in a comatose state. The etiologies are extremely diverse. So use that table I showed you if you get encephalopathy, and just work your way through it and do the standard tests that I mentioned. You will have a high success rate at diagnosing it, I suspect. It's very important early on to treat the aggressive etiologies before you have the full amount of information, particularly HSV encephalitis, because that can run away on you and even within 24 hours produce a lot of damage. And always remember, I didn't focus on the treatments too much today, but because once you know the diagnosis, you can look those up and you can treat the patient accordingly. That's not the hard part here. The hard part with encephalopathy is making that diagnosis. And once you're armed with that, you can be confident in your treatment. And the treatments are often quite straightforward, and many of these encephalopathies can improve. But again, I can't emphasize it enough. The problem with encephalopathy is when you're not quite sure of the cause of it. That's where the problems occur. So emphasis is on diagnosis in this one. Thanks very much.